Greetings, everyone. My name is David Heath, and I'm a fourth-year emergency medicine resident in the Cleveland Clinic Healthcare System here in Ohio. And just like you, I'm also a doctoral student in the athletic training program at ATSU. So welcome. I live in Stark County here in Ohio, which is a little bit south of Akron and Cleveland, maybe about an hour south of Cleveland. And about 2 or 3 miles from my house here, we have the Pro Football Hall of Fame. So I would like to at least put a plug in that if you ever come to Ohio, I would emphasize that we do have an enshrinement festival in the summertime for the inductees. So I encourage you to come to that in the summertime. It's really, really fun. And happy Athletic Training Month to everybody. A couple of housekeeping issues quickly as we move along. I'd like to thank the 2 course instructors here for making this transition to online courses a smooth one for me. It's been exceptional. I would also like to thank my colleagues for all the instructive feedback, comments, and questions that they've posted. I'd also like to say that it's good to put faces and voices with the names after this series of videos the last 2 weeks, so it's been very good for that. So, are opioids the tool of the devil, or are they simply misunderstood? And for that, I'm going to leave that up to you to decide. But that's kind of where my quality improvement project came from. As an emergency medicine physician, I do see a lot of opioids come into the emergency department. And when I was an athletic trainer full-time, I also saw a lot of that being misused in the high school and college settings. The most common thing that brings people to the emergency department or to seek any health care whatsoever is usually pain. And that's the most common reason people come to the emergency department. The Journal of the American Medical Association, JAMA, published research from 2009 saying that there are over 200 million opioid prescriptions dispensed in the United States alone. I did some more research and found in 2012 that Ohio had a record number of deaths, almost 2,000 people from unintentional drug overdoses. And surprisingly, the United States uses over 80% of the global supply of opioids, yet we only constitute about 5% of the world's population. The DEA also did some research demonstrating that over 50% of adolescents, which is the age group that we're studying with this policy, over 50% of those individuals say that it's easier to obtain prescription narcotics rather than illicit narcotics. And what's concerning to me is, as an emergency medicine physician, I found out that 12% of all opioids dispensed in the United States are by EM physicians. Very disturbing to me. So it appears to me that the prescribers are part of the problem and not the solution. So that's what I'm trying to fix here. Now, in our facility, it further reinforced the problem that 1 out of every 4 people that we saw last year fell into primarily 2 categories, either acute exacerbations of non-cancer pain or minor musculoskeletal pain. And disturbingly, 95% of those individuals left with outpatient opioid prescriptions. So again, that kind of reinforces that we are, unfortunately, part of the problem. Yeah. And this is our medical center here. This is our level 3 trauma center. We see about 30,000 individuals per year in a 24-bed emergency department. This is just a quick video of our emergency department. This is a view from room 16 all the way up to room 22. So my aim of this policy, this quality improvement project, was an attempt to decrease the amount of outpatient prescriptions for opioids to a specific age group. So adolescents from ages 10 to 19 in our emergency department. And my goal was to do that within the next 6 months, and the value was to try to decrease it by 40%. So if we zoom in a little bit on the healthcare system, we'll see under that umbrella that there are numerous causes that affect the healthcare system, which includes lack of primary care physician care, the inability to obtain insurance. Sometimes they have formulary restrictions where they can get one drug and they can't get another drug. Those type of things. So the system in general. Focusing on the patient themselves, quite frankly, they may be there just for narcotics, unfortunately. So they may exhibit aberrant drug-related behavior. It's unfortunate, but true. They may be taking other narcotics, other drugs. They may just have a low socioeconomic or low education status, or have comorbidities. Hard to say. But those are all contributing factors toward the patient. If we focus on the provider, so, us, we may just not be following the policy. Whether it be consciously or unconsciously, that could just be the case. Due to a knowledge deficit or the inability to access the patient's old records, all of those kind of contribute to why we do what we do. And the last thing I'll mention is sometimes we could be actually afraid of the patient, medico-legally. Can they complain on us? Will our Press-Ganey scores go down because we don't give them narcotics? Those type of things with the provider. And lastly, the organizational structure. So our system, the Community Health System, CHS, out of Nashville, they do not have any structure whatsoever with regard to opioid policies in any of their emergency departments out of their entire 200 hospitals. So this is somewhat of a new thing to them. So they may be a little bit reluctant to incorporate this, but hopefully the Medical Executive Committee will approve this in a few months. So that could be an organizational hurdle. And additionally, they could have medical legal concerns too. What if you post signs that look like you're turning patients away, right? So those are things that could potentially lead to the effect of this preventable opioid-related adverse drug-related effects. Well, this is the specific flowchart diagram for the opioid policy. And I'm not going to go over the entire thing with you. That would take up entirely too much time. But I will focus in on 2 points. Number one, the prescriber and the primary care physician are important components of this algorithm. And number two, the pain agreement is also an important portion of the algorithm. The primary care physician will be contacted if one of their chronic pain patients presents to the emergency department. And as I mentioned in my text, we're trying to contact primary care physicians within 50-mile radius of the hospital so we can get a list of their chronic pain patients and copies of their pain agreements. Drugs aren't all bad. That's not the point of this entire policy, of course. But what we need to realize is prescribing narcotic pain medication isn't appropriate in all cases, and primarily for the 2 conditions I have listed there, the acute exacerbations of chronic pain and minor musculoskeletal injuries. As providers, I encourage you to practice practice narcotic stewardship. You all are in the trenches, as I am, but you're going to see athletes abusing narcotics, unfortunately. And I hate to say this, but as physicians, we are as much part of the problem as we are the solution, unfortunately. So that's what I'm trying to maybe assist with for us becoming more of the solution rather than the problem. And with that, I thank you very much. And again, as always, I encourage your instructive feedback, questions, and comments. And thank you again. Bye for now.